Hey everyone, welcome back to my channel. And if you're new here, I am Mariana and I interview the brightest minds of physical therapy. So if you want to increase your knowledge, start right now by subscribing to this channel, clicking on the bell so you don't miss anything, give us a thumbs up and share with your friends. Today, our guest is Dr. Ron Donaldson, and he will talk about how to bring PCPs onto the team to greatly increase the MDT exposure for patients. Dr. Donaldson is board-certified orthopedic surgeon, a non-operative spine specialist, and a diploma in mechanical diagnosis and therapy. Dr. Donaldson is the founder of SelfCare First, an online platform providing evidence-based educational MSK content for patients, allied health professionals, and physicians. I hope you enjoy the show. Hi, Dr. Ron Donaldson. How are you today?
I'm just fine, thank you. How are you?
I'm doing well. Thank you for coming here and discuss with you today. So we are going to talk about PCPs and MDT. So I think that's going to be a very interesting conversation because that's a question that many people and PTs have about how we can engage PCPs with MDT and get more exposure. So let's jump right in. Could you just start telling us a little bit about yourself, your career, your background?
Sure. I'm an orthopedic surgeon, and I started off many years ago in sports medicine. And in those early years of my practice, I was introduced to a type of spine care called mechanical diagnosis and therapy by the only therapist I had in my small town in Vermont. I didn't have any big interest in spine care at all. I was into sports medicine. But over the next few months and years, when I did have a spine problem, low back pain patients, I sent them to him. And it was quite clear that these folks were getting better very quickly. And you doing some things that were unusual for me in my background. So that became intriguing. And I became more and more exposed to this type of care and how many people it helped. And at the same time, I became aware of how badly we needed to improve low back care. There were far too many people getting surgery. And so it became more intriguing how important this was in healthcare completely. So I started to get challenged by those things and became increasingly interested in this and started wanting to see more back pain patients because of this success. And so I, over the next 8 or 10 years, I transitioned from being interested in sports medicine to spine care. I stopped doing surgery because my spine patients, for the most part, didn't need it. And I went from a small town private practice back to the academic center where I did my orthopedic training. And I joined up with two of my colleagues there, and we formed a spine institute. They were the spine surgeons, and I was the non-operative physician. And so that was all very exciting. Meanwhile, there was nothing published about mechanical diagnosis and therapy, so I started tracking patients of my own and ended up publishing the first paper on centralization of pain back in 1990. And that was really pretty exciting to finally get something in the literature about that. And so that took me to 1990. I stayed in that academic center all through the 90s and wrote a couple books and published some papers. And I really got pretty involved in this and found it very, very rewarding and exciting to be able to make such a contribution because I learned all through this time how important this was.
And now my question is, when did you start studying MDT? So if you published in 1990, when did you start having contact with MDT and studying it?
Well, I mean, the physical therapist in Vermont that was treating my low back patients, he was my teacher. He had been going to courses with Robin McKenzie, and as he puts it, he brought me along slowly so that I could learn about this and appreciate it more and more. So he was my primary tutor, if you will. But I met Mackenzie through him right away, and I started taking some courses uh, with Mackenzie, the standard courses that therapists take, and they were very exciting courses, I thought. And uh, and through Greg and through Robin McKenzie himself, I met all the other American faculty and the international faculty. Uh, and because here I am, an orthopedic surgeon interested in their physical therapy topics. So that was very exciting to them to have an orthopedic surgeon who was paying attention to them. So we started to develop some really great relationships, and that led to some projects, some research projects, and so I started getting invites from those types of people to speak because everybody wanted to hear from an orthopedic surgeon, and so it all just slowly developed.
Yes, I think that's so exciting. And what I think is great is that you, as an orthopedic surgeon, being interested in the McKenzie method, it's kind of giving up your profession, not giving up, but now you are trying to help them in a different way. So I think that's very interesting how you had the courage, I would say, or the ability how you did to switch careers like that. I think it's very intriguing.
Some of my friends describe me as a recovered surgeon, and as I started just doing non-operative care, and it was so important and helped so many people that in itself was very exciting to be able to be in a position to help people like that with something that was so universally acceptable, almost universally acceptable across the spectrum of low back issue problems.
Yes. And then seeing good results and being able to help the patients without having to operate them on them. I think that's very neat. Um, so in med school, we know that they don't have that much of the training, right, on musculoskeletal disorders. So would you share with us how was your MSK training experience in med school?
It was traditional orthopedic approach, which primarily focused on surgical solutions and how to diagnose a surgical problem. And so uh, there wasn't anything in med school that had anything to do with non-operative care, other than what you might read in the guidelines, and that is don't jump too early. Give people a chance to recover on their own, and and utilize physical therapy. But it was very non-specific therapy, and so there was nothing very special in my view about this type of care, but because because I had switched to non-surgical care and had switched to an academic position, I was in a position to start teaching these MDT principles to medical students and to our orthopedic residents. And there are some of those residents, just from that exposure, practice MDT now. The years later, they use MDT or think very favorably about it in their own practice.
I think that's amazing that you're able to have that impact on your area. Um, and now, do you think that nowadays the MSK training in med school is still the same, or do you think that changed? I don't know if you have any contact with anyone these days, but do you think that the training evolved in the sense of the MSK that you received in med school?
I think there's a little more exposure to it or familiarity with it in med school and in specialty training, like whether it's orthopedic surgery or physical medicine rehab, just because there's more in the literature about it. Having said that, its utilization is very weak. But so I mean, I know dozens of doctors across the country that use it regularly in their practice, but that doesn't begin to compare with all of the clinicians that are out there serving these patients or trying to serve these patients. So it needs far, far more exposure to the clinical groups that care for these problems.
And why do you think that MDT is not widely known in the PCP world?
In the PCP world, because there's probably several reasons. One is it's not in their literature. There's been a lot of papers published, but they've all been in the orthopedic or the spine or the physical therapy literature, which the family medicine docs don't read. And so the family docs mostly rely on clinical guidelines to help them in how to care for these patients. But the clinical guidelines are very poor. They teach myths about low back pain. The main one they teach is that most low back pain recovers on its own. Well, we know that's just not true. Some does, but an awful lot doesn't. And so many people go on to develop chronic problems or go on to unnecessary surgery, all of which is terrible care. But family docs don't know how to differentiate. And so that's one of my projects is trying to teach family docs about MDT and about all the poor care that adds to the chaos that exists today in how these problems are treated.
Yes, absolutely. And so I think that's the question everybody wants to know. So how can we bring PCPs onto the team to greatly increase the MDT exposure for patients?
Well, I think a large number of family medicine docs appreciate that they don't have good training and they really don't know what they're doing in musculoskeletal and in spine cases. And so they're open to hearing things. So I don't have much trouble getting them interested in talking. And in that vein, I've developed a virtual course for family docs. It's a little over 3 hours in length that teaches them about the shortcomings of current musculoskeletal and spine care, as well as the real quality and advantages of MDT care and what it does to help the primary care doc deliver really high value care to their patients. So that course is now available, and it's principally for primary care docs, nurse practitioners, physician assistants, all the primary disciplines who see these types of problems on a regular basis.
Yes, no, I think it's great, and it's great to know that, because a lot of times we have conversations with doctors, and many of them, they don't know, or they never heard about MDT. And I think that's particularly difficult with some doctors, for example, that they also don't understand how we can do like MDT, for example, virtual. They are osteopaths, so they are very hands-on. So some of them that I approach, they are like, yeah, I don't understand how you can do this. I don't think that's possible. My patients, they want in person, or because they don't understand exactly what we do and how we can change. So I think it's a very good resource that we as PTs, when we have those conversations with doctors, have something to show them that they can go and check it out and help this way. Because I didn't know that you had this course. I just learned when we start talking about it. And I'm gonna go back to all these doctors that I talked to through my emails and send them, because it's different. If it comes from a doctor, I think they're going to respect more and be more open to see what this doctor is doing. So maybe they're getting intrigued and curious about what is this, and they go and check. So I think that's awesome that we have this resource. We can put this link on the show notes so people can go after and take a look. And I think if everybody starts doing that, it's gonna help us with our relationship with doctors and helping them understand how we can help their patients in a different way. And maybe even them would be even better if they get interested in studying, understanding MDT better, right?
Yes. Well, you're absolutely right, and I think most medical doctors, one, recognize that they don't have good training, but they don't know who to trust to get good training, and so they're kind of lost. And one of the beauties of MDT that we've all appreciated is when we can see a patient turn around quickly and see pain centralize and see a directional preference in action. And so that type of thing is what I have within this course, so they can actually see how quickly things can turn around and how quickly and how simply they can turn around. And so that kind of whets their appetite, and then they're interested in learning more. But a lot of them are hungry to know more. They just don't know where to get their information. And they've had so many other clinicians and therapists approach them with their kind of care. But these docs have learned that, well, that's not necessarily all that great either. And so they're open to learn, I've found. And if we give them quality education in a very palatable way, and my course is divided into 15, 20-minute segments, so they can listen whenever they have a few minutes in their day or in their evening, because they're so busy they don't have time to go to a course. But yet, after seeing some of this information, they become more interested and are willing to go to a course. And I would say a large number of docs that have gone to Part A McKinsey course come back and say, that's the best course I've ever been to, because they
Oh,
actually
wow.
see patients turn around. They see it working. And that is so different than what their own personal experience has
Mm-hmm.
been. It's really very
Mm-hmm.
impressive. And so they gradually pick up on the value of it.
Yeah. So what you do on the course, you just expose them to the basic concepts of MDT. So to get them curious about it and trying to see if they would be interested in doing the
Yeah,
whole.
but I first introduced them to all the flaws that's in conventional low back care. The fact that low back pain is a symptom; it's not a diagnosis, and so we need to find a diagnosis, but we don't know how to get a diagnosis, and so there are other ways other than anatomic structures that can give us clues, like directional preference uh, and or pain centralization. Uh, they need to know that not everybody gets better. They're taught that low back pain, most back pain patients get better on their own, and they don't. And so the the burden of disease report says that uh, low back pain is the number one cause of disability. Well, how can that be if it has such a favorable natural history? that's a complete contradiction. And so in this course, I list 7 different flaws, 7 different myths that are flaws that are commonly held that we challenge on the course. So we start off with talking about the shortcomings of current care. And then, of course, we transition through Mr. Smith and pain centralization and start introducing what can happen that is so favorable and so commonly useful in helping people recover rapidly and easily.
Yeah, and then I think I heard you saying earlier on your webinar that is about 3 hours, the whole course.
Yes.
Yeah. Okay. Great.
As I said, it's divided into modules, and they can look at the modules at their own pace. So
Awesome.
that enables them to work their way through it without having to put out a whole block of time away from their practice and away from their family to listen to all this. They can just listen at their own pace.
Awesome. And how can we create a team-based approach coordinating PCPs and MDTs?
Well, that's really what this course is about, is how to marry these two, because you really need both. The family physicians are the attraction because patients go to them for care, but then those doctors can introduce the patients to MDT. And so the more the docs know about MDT, the more effective they are. But one of the main themes of this course is to coordinate the care of family physicians with MDT.
Yes, and how do you think it would be a more efficient way of doing that? So would the PCPs being responsible for the triage and then kind of referring the patients to an MDT clinician when they think that's going to be a good fit? Are they themselves treating the patients?
It's up to them. I mean, there are ways that they can do either of those. They can get trained themselves, and some of them want that, but that's quite a time commitment.
Yeah.
But there's a number of physicians that are credentialed MDT clinicians, or they can refer the patient to someone who is credentialed and trained in MDT. And the fact that we can now identify really good virtual care, and that MDT is beautifully delivered virtually, because it's the one approach to low back care that doesn't require touching the patient, and it doesn't require any equipment like you'd have in your office. So you can do it all virtually with video. And that works very well because it has the added feature that they don't have to come and see you. They don't have to drive. They don't have to do all that. And so therapists and chiropractors are having great success delivering MDT virtually.
Yeah, and I think that if they just know that MDT exists and how to refer the patient, it's a big change that we can have on the system. And then also just sharing one experience that I had with a direct to primary care. She was open to trying these, and then I saw her patient virtually with her on her office, and they were shocked with the results that were so quickly, with shoulder pain that was coming from the neck. So she gave me the chance of treating her patient in front of her. So I think that was awesome to just show that experience, that the pain, rapidly reverse pain and all of that these concepts that they don't, they are not exposed to. And but that was like a very positive experience that I had. And then many others, they just are not open to this kind of experience. So I'm really happy that I have this resource now to send them and see if that helps and get their attention to learn a little bit more about that. So I think that's very exciting.
You as a therapist, you can deliver MDT virtually, so you don't have to find another clinician to do that for you. Uh, you can learn from other clinicians that are doing it virtually to become a little better at it. But uh, there are the virtual delivery of MDT is outstanding, and it's going to revolutionize spine and musculoskeletal care. And because again, you don't need equipment. They don't have to. They don't have to get in their car and drive someplace to see you. And it's just so convenient and so effective. And it's always been whether you're teaching a course to a room full of doctors or you're having a one-on-one session. What the power of the teaching is when you see pain change as a result of directional movements, test movements. And that's a powerful teaching tool. And to be able to deliver it virtually makes it even that much more attractive.
Yes. And how do you think an advice to physical therapists now? How can we start these conversations with doctors? Do you think it's trying to show the method in action, like trying to show the results? Is there a way that you recommend how we can approach these doctors to get their attention? Because I'm sure a lot of people reach out to them every day. So how we can start this conversation and get their attention?
Well, first of all, realize that doctors want this education. They don't understand it. They want to know more about how to treat these patients that they see so often. They don't like referring these patients to specialists, and they recognize, most of them, that MRIs aren't that helpful. So they're very hungry for some other types of care. And so then when we offer them this type of care that is so rapid, that is so easy, that is so safe, that is so inexpensive, that doesn't need imaging, it doesn't need injections or surgery. I mean, it has all the positive things that they are looking for their patients. And so I think the best tool right now for educating them is this course of mine that introduces the whole topic, what's bad about current low back pain, as well as what's good about MDT, and the results that are published. And that to me, uh, I wanted them to get that whole package.
Yeah, so that's the way. Send them the link to the course and hope that they're gonna check it out.
Yeah, I mean, you can't force them. I mean,
Yeah,
if
yeah,
they're not interested enough to press a key in their laptop to go read
yeah,
about this, listen about it, then they're not really ready. They're not interested, and that's fine.
yeah,
Move on, next
yeah,
person, because there are plenty of people, plenty of clinicians that are interested.
yeah. I agree with you 100%. Um, Now transition to our final questions. What is your favorite resource of information? Any books, specific papers you like? I know you wrote many books, so do you have any resource that you like in particular?
It depends on what you're looking for. If you're looking for McKinsey content and techniques and so forth, then of course there are the McKinsey books and the McKinsey courses and so forth, uh, which are which are excellent. There are many of McKinsey clinicians are now publishing papers, and they have podcasts where they discuss many different relevant topics to the clinician. And so there's an increasing amount of information that's available online. Uh, so I don't, it depends a bit on what you're looking for, but between the courses that are published, the books that are published, the podcasts that are available, there's no shortage of information about MDT.
Yeah, absolutely. We can find a lot of things online. The technology really helps us to be able to research, find papers, anything we want, and find books online. So that's amazing. Um, and then, what would be the best advice you give to the clinicians that are starting their careers?
MDT, just the evaluation, serves so well, whether you're talking about a low back or neck patient or a shoulder, hip, knee. If you don't get that evaluation right, you're not going to be happy, and neither is your patient. And so it all starts with the evaluation and the diagnostics that are so strong and powerful in the MDT curriculum. So too many therapists just focus on treatments, and they're not aware of how much help they can have for themselves and their patient by making a more accurate diagnosis.
Yes, that's very true, because if you don't have a good diagnosis, are you treating, right? You don't even know what you're treating.
That's
And,
right.
and what personal qualities or abilities that you think are important to become a successful professional?
An open mind
Mhm.
to and to explore new ideas that you come across in your reading or in your coursework or with your colleagues. But you want to, while you're doing that, you really want to focus on how can I make a better diagnosis? How can I get a better handle on what's wrong with this patient? Then maybe I can do a better job selecting an effective treatment. But you've got to have an evaluation that's meaningful to identify in most cases, a reversible diagnosis.
Yes, absolutely. Open mind, being willing to learn and see different techniques and see if there is something else out there that it's been better than what you've been doing, right? And trying to improve.
And
Awesome.
don't get stuck on treatments. Get stuck on an evaluation and trying to identify what category this patient fits into,
Mm-hmm.
what type of pain do they have, and then what do I have to address that type of pain.
Yeah. I think when we graduated, at least in PT school, we are like, I was thinking, I want to learn all the techniques. I want to know everything. I want to, have a solution for each problem. And then when you don't focus as much on the assessment as you focus on the techniques, you want to be the best at all the techniques. And then you start understanding that that's not the most important thing if you don't really know what you're treating. So I think it makes all the
That's
sense.
good. That's exactly right.
Dr. Ron, if people want to contact you, find more information about you and your work, how they can find you?
Very easy. My email address is Donaldson at selfcarefirst.com. And that's where you can learn a little bit more about me, but that's where you can access information about the course and register for the course and so forth.
Awesome. I'm going to make sure to put your email, your website on the show notes so people can go and check, and hopefully other PTs can share this link with the doctors that they've been talking to and doctors that may listen to this podcast. So we're just here trying to spread the word and improve our patient care, right?
Exactly. So don't be shy about emailing me your questions. I'm very happy to respond.
I appreciate you taking the time and sharing with us all this information. I think it's amazing the work you are doing, trying to connect the PCPs and MDTs and trying to be the link between them, because I think that's very important, and especially to deliver the best care and the deliver the care for the patient. That's the most important thing we want here. Just everybody should have the ability to have a good assessment and a good treatment.
Well, so many people go to their primary care docs for answers.
Yeah.
To their musculoskeletal and their spinal problems. And if the primary care doc just focuses on a particular treatment that he or she likes, that isn't much help. You really need to have some knowledge about how to identify the underlying cause, in which case, in most cases, does it have a directional preference? Is there a single direction of movement that changes it for the better? And how do we identify that? And those are the things we should be pursuing with our patients. And that's what I'm interested in introducing family practice to.
And help a big part of the population that they don't know that they can help in a meaningful and quick way and with long-lasting results. So
that's right.
Awesome. Thank you so much, Dr. Ron. And
You're very welcome. You're doing a great job by bringing attention to these questions and this type of care that's very important to a lot of people.
Absolutely. That's our goal. Thank you so much.
You're very welcome. My pleasure. Bye-bye.